Welcome to our February EMSC Collaborative Works webinar. I'm going to tell you right up front, we're using Zoom webinar for the first time. So there's a few things we're going to do a little different, and want to point out as we go forward, you can chat to the hosts or panelists direct to us, or you can, what we really prefer, if you have a question, is to please post it in the Q&A, and we'll be monitoring that and using that to facilitate the discussion or questions with Dr. Fallat. With that, I'm going to turn it over to Dr. Marianne Gashi-Hill for introductions.
Hi there, everyone, and welcome. There we go. We're really pleased to have Mary Fallat. I've worked with Mary probably over 20 years, off and on, to advocate for EMS for children, as well as for pediatric readiness. And we're really lucky to have her today. She's a professor of surgery at the University of Louisville, where she's been in practice for over 35 years. And as I said, Dr. Fallat has a long history of advocacy as well as service and leadership in pediatric surgery. Interest areas for her include surgical care, trauma, EMS for children, particularly in rural and underserved areas of the country. She also has looked at ethical issues in children's surgical care. She completed 2 terms as the member of the National EMS Advisory Council representing the trauma sector, was a member of the ACS Committee on Trauma, and is the immediate past first Vice President of the American College of Surgeons. Dr. Fallat has been funded by the Health Resources and Services Administration as Program Director for the Kentucky EMS for Children program since 2004. She serves as trauma advisor to HRSA, Health Resources Services Administration, EMS Innovation and Improvement Center, as you all know, the EIIC, and to the National Pediatric Readiness Project. She's sub-PI for an awarded HRSA grant to develop a national pediatric pandemic network. So with that, I really look forward to hearing your comments, Mary, and look forward to everyone who's participating for your questions. Thanks so much for joining.
Thank you all. I'm going to screen share. Dr. Gashi-Hill helped me pick the topic. And what I wanted to do, since I have a special interest in trauma care, is speak a little bit about the sphere of influence that comprehensive trauma care brings to regional pediatric preparedness. As Marianne mentioned, I have been involved in EMS for children for a long time, and now I'm involved in the Pediatric Pandemic Network. And I will say that being in EMSC gave great preparation for being part of the PPN network. As she also mentioned, I do receive some salary support through both of those HRSA programs. And as I was putting together this talk and thinking about you as the audience, I tried to envision some of the questions that you might ask with respect to trauma care in children and relative to present day. So one question is, why emphasize trauma when infectious disease seems to be so prevalent and in the news? Why can't all injured children get transported to tertiary and quaternary care? Why should trauma surgeons be interested in pediatric readiness? Where does burn care for children fit in? Why should trauma system development include both children and adults? And why should a trauma system be integrated into state planning and development? So these are some of the things that we'll discuss briefly. It's sort of a tall order in 45 minutes to give you time for questions. So we'll go through each one of them in some brevity. So the first question is, why emphasize trauma when infectious disease seems to be in the news? We just went through a big pandemic and then a triple-demic. And I think most of you are probably familiar with the recent article that came out by Rebecca Cunningham and her group in the New England Journal that looked at the, let's see if I can get rid of this here, that looked at the mortality rates and deaths per 100,000 children and adolescents for the 10 leading causes of death in the United States from 1999 to 2016. And I will say that there's a caveat in most of the papers that you read about mortality in children. You have to look at the ages that are included, because no one can really agree on what the age of a child is. And furthermore, most of these databases use different ages, but this is 1 to 19 years of age. And you can see here that motor vehicle crashes and firearm related injuries are right at the top of the list for causes of death. Cancer, malignant neoplasms is here. Suffocation is here, congenital anomalies, heart disease. So all of those pale by comparison. And if you look down here, here's chronic lower respiratory disease way down here. There was similarly a release of information from the CDC for the same time point. And one of the highlights here is just the disparities in how mortality affects different populations. So you can see poisoning and drug overdoses are actually higher among Hispanic children, and poisoning and drug overdose death rates are higher among Black children. Suffocation death rates are higher among Black children. Motor vehicle death rates, again, are in the Black population. So there are some real disparities in how injury happens in our country, and something to think about when you're taking care of kids and when you're thinking about injury prevention. This was a study that was put out by Lois Lee. It's a very elegant paper that looks at firearm-related injuries, and there are many figures in this paper, but in particular, I wanted to point out the homicide, firearm fatality rates by state. The deeper the color, the higher the rate. And in this paper, Dr. Lee and colleagues look at 0 to 24 years of age. And so those are really young adults. But in the age groups that are higher, you can see there's a real significant increase in the mortality rates that we've seen in the last several years. I also wanted to just compare it to infectious diseases. And so on the left, you see a graph where I asked the question, how many children died of COVID? And this is a graph that looks at all ages. So over 1 million people in this country died from COVID during the pandemic. But of those, only 0.16% were actually children or less than 18 years of age. And on the right, you see a graph that looked at change in death rate by cause of death. And this was during the pandemic. And of interest, these trauma mortality rates went up in firearms, car accidents, burns, and then assaults. And influenza and pneumonia went down. And so hopefully I've been able to convince you that even though sensationalism has put a lot of the respiratory illnesses towards the top, trauma is really still the leading cause of children. And more recently, here, if you look at unintentional deaths from 2010 to 2019, more than 7,000 children die each year of injury. And here's some statistics about the flu season. And so any death in a child is tragic, but we certainly have a lot of deaths due to trauma in this country. So now let's segue into why can't all injured children get transported to tertiary and quaternary care? So this is a map some of you may have seen, but it's all the community hospitals in the United States. It comes from the American Hospital Association. and there are over 5,000 hospitals that call themselves acute care hospitals. And of these, nearly 2,000 are rural hospitals. But the more important point on this slide is that only 279 of them are children's hospitals. So how did we come up with that number? There was actually a very nice paper that came out in 2020, and they looked at AHA data from 2015, at which point they looked at a little over 4,000 hospitals and put them in 4 categories by tiers. So tier A was care to children only. There were 51 hospitals. So those are freestanding children's hospitals. Tier B have all the key pediatric services, 228. So these are likely the children's hospitals within a hospital. Tier C is limited pediatric services, and tier D is none. And the last category was unclassified. So there's still quite a big amount of care in these 738 hospitals. But you can see that these hospitals, which are the most, the highest number, don't have many pediatric services. And then this chart from the same paper looks at admissions designated as pediatric by tier. So obviously tier A is going to have the most, and I think this last 11% are those special needs adults that come to children's hospitals. And those are individuals who are over 18, usually between 18 and maybe 24, and we still take care of them in our ICUs. This is tier B, and pertinent to this tier is you can see that it's only 10%, and that's because many of these children's hospitals within a hospital are part of a system, and the system of care is predominantly adults. But I thought it was quite interesting that in this unclassified group, as much as 28% of the admissions were actually pediatric. So let's talk a little bit about access to pediatric trauma care in our country. This is a busy slide, but I'll break it down for you. So here are all the American Burn Association verified burn centers in the country. Here are the level 1 and 2 pediatric trauma centers. On this lower right are the level 3 and 4 adult and pediatric trauma centers. In the middle are level 1 and 2 adult and pediatric trauma centers. And over here is the map that you saw before. That is all hospitals. So you can see that there are big areas in our country where we do not have centers of excellence or those tertiary and quaternary care centers that we've all come to know. I wanted to show this slide again. These are the adult level 3 and 4 centers, and these are pediatric level 1 and 2. So once again, there are a large number of these lower level adult trauma centers that often do not take care of children, i.e. they don't admit children, but that is a real area of opportunity for us, at least in terms of pediatric readiness. So pediatric readiness is defined as ensuring that every EMS agency and emergency department has the pediatric specific champions, competencies, policies, equipment, and other resources needed to provide high quality emergency care for children. You notice it doesn't say anything about the infrastructure of the hospital that would allow admission of children to that hospital. And so we have a lot of recognition to do that not only are we talking about emergency departments that often aren't capable of taking care of children, we're talking about places in the country where they just don't want to admit children, nor do they have the pediatric nurses, pediatric anesthesia, or the other elements, pediatricians who come to the hospital to help take care of patients, so that the things that surgeons might need to help them with patient care. However, over 80% of children are actually seen in these emergency departments. And so the work that we have to do, and remembering that not all of these are trauma centers, are to be able to make these emergency departments capable of at least seeing, helping to diagnose a problem, stabilize, communicate with other centers, transfer if necessary, send home, and to see the pediatrician the next day if that's the best plan. Not every child needs to be admitted, but we do need to have a system of care that's more comfortable taking care of children. Likewise, we have EMS providers who may practice in areas where they rarely take care of a child. Even in Louisville, Kentucky, 6 to 7% of the runs are children. And many of those children are really not terribly sick or terribly hurt. And so the chance that an individual EMS provider will take care of a child who is really sick or really hurt is small. There are states now that have fine pediatric readiness recognition programs, both at the emergency department level and the pre-hospital level. Fortunately, they're growing in number, but there still are places where these don't exist, or where, like in Kentucky, we're building these programs, but it's certainly not 100%. Most of you are familiar with the different aspects of HRSA-funded programs, but I just wanted to give you a snapshot of each to help you put in perspective what they do. So the EMS program, which has been around since, the partnership grants have been around since about 2001, improve emergency care for kids by helping first responders and hospital emergency departments be pediatric ready to provide the best possible care to children. The EMS Innovation and Improvement Center, which is in its second stream of funding, uses research to develop strategies to help medical professionals understand how to take better care of children who need emergency care. So this is the evidence-based part of the HRSA programs. And then the newest is the Pediatric Pandemic Network, which collaborates across the country with children's hospitals and their communities to provide the best possible care to children in emergencies, disasters, and pandemics. And we've recognized that we can't take care of kids in a pandemic if we aren't ready every day. So we're in the third year of funding, and really a big focus is to help the other HRSA networks improve pediatric readiness as we start to build this pandemic network across the country. And I will add that I'm extremely grateful that trauma and burns were part of this all hazards plan to develop this network. On this slide, you see the governmental federal branches that provide care for kids. Here is the HRSA network. So we're all sort of together here, along with the National Pediatric Readiness Project. Over here are the Centers for Excellence. So this is where WRAP-EM is, and I'm cognizant that I'm also speaking to many people who are in the WRAP-EM Center of Excellence today. And then over here is FEMA. So ASPR is the HPP programs, and FEMA is emergency management. And when you have a disaster, all of these different programs have to come together and unify to take care of people, both children and adults. So the next question I wanted to focus on is, why should trauma surgeons be interested in pediatric readiness? And I think you can infer a lot by remembering those maps that I showed. But there are also more than 60 articles now that have been written and documented that pediatric readiness does save children's lives. And a subset of those are on trauma, and have given guidance to what element of pediatric readiness a hospital needs to have to really recognize that benefit. We know that high pediatric readiness is associated with a lower mortality rate in ill children, a lower mortality rate in injured children, and several children's lives are saved across the country each year because of it. But I think one of the striking things to remember, and that is being pointed out in some of the more recent papers as well, is that the score of a hospital has to be somewhere between 87 and 93 to be able to recognize that mortality benefit. So once again, we have a ways to go before we're there. I wanted to remind the audience that pediatric trauma is really a continuum of care, and injury prevention is really the gold standard for trying to even prevent a child from needing access to care. But we're talking about access and then pre-hospital transportation and emergency departments. This is really where we're focusing today, on that first leg of the journey of a pediatric trauma patient. Pediatric Readiness has had many champions, and I'm pleased to say that the American College of Surgeons is now one of those partners in Pediatric Readiness. And as of August of this year, there is a standard in the Optimal Resources book that was released in 2022 that is important for pediatric readiness. It does not lead a hospital to a certain score. What the three things are: that you have to have done the checklist, you have to understand the gaps that your hospital emergency department has, and you have to have an approach to those gaps. And this is a 36-month period for hospitals that are verified by the American College of Surgeons. Remembering that the hospital verifies levels 1, 2, and 3, and many of the trauma centers in the country are level 4 and 5, especially in rural areas. So they are not held to this standard yet, unless a state puts it in regulation. And furthermore, there are many states where the college does not verify the trauma centers. They're verified by the state. And so until that state looks at its statute and regulations and decides to adopt those of the American College of Surgeons, this particular standard will not be part of the trauma center verification for that state. I also wanted to just say a word about TQIP. So TQIP is the data arm of trauma verification for the American College of Surgeons. You do not have to be verified by the college to participate in TQIP. It's the Trauma Quality Improvement Program. There's also a pediatric arm of TQIP. And trauma verification actually started in '87, and TQIP was introduced in 2008. And pediatric TQIP, which was a later addition, did not start until 2014. Probably because of that gap in years, and also because children tended to be an afterthought in terms of trauma system development, the adult metrics, at least at first, were applied to children, but they really don't apply to children as well, because we're talking about ventilator-associated pneumonia, and we're talking about mortality, which is always less in children. And so really what needed to happen is that the pediatric data metrics needed to morph to the childhood population. The level 1 and 2 verified trauma centers must participate in TQIP. However, there are some level 3s that have formed collaboratives and that do participate, but not every trauma center that's verified by the college participates in TQIP. And benchmarking does not include many verified centers that take care of children, because there are a fairly large number of children who are cared for in level 1 or 2 adult trauma centers, where their data is entered into TQIP, but it's not included in the reports because those centers aren't verified to take care of children. So recently, Dr. Melhado and the senior author is Aaron Jensen, released a paper called Benchmarking Pediatric Trauma Care in Mixed Trauma Centers. Adult risk-adjusted mortality is not a reliable indicator of pediatric outcomes. So they actually were able to look at all of the pediatric TQIP data that hadn't been included in reports because they were children cared for in centers that weren't verified for children's care. And they were able to compare that to the adult centers and the adult metrics. I was privileged to be able to write an editorial for that because it basically shows that the adult mortality metrics overestimate pediatric quality in mixed trauma centers, and that it really appeals to trauma surgeons that, as well as I think to the College of Surgeons, that pediatric specific benchmarks need to be required for centers that admit children. So how would that look? Well, I think we need to consider a culture change in how we view children's care through the lens of quality, TQIP, and trauma verification. And what do I mean by that? First is we need more appropriate TQIP metrics for children that really drill down into the aspects of pediatric trauma care. But in addition, I think that hospitals that care for children and put their data in need to be able to see the benchmarking reports of how they are caring for children and what they look like relative to the population of centers that are verified to care for children, so that there's pediatric benchmarking for all of the TQIP centers. Having said this, I think that pediatric trauma surgeons also need to look at where injured children are cared for, and we need to help to improve the pediatric readiness through team building, through collaboration, and that we also need to recognize the contributions of our adult colleagues in pediatric trauma care and encourage them to verify their centers for children's trauma care, because we all know it's a team effort and it's a package. If you're just taking care of children and admitting them, but you don't have a program manager for them and a QI program, and you're not really doing a team building approach to the care for those children and looking at it with the lens of how other centers are caring for children, I'm not sure that you're providing the best care to kids. So what are some other ways that we can improve the workforce for taking care of children with injuries? Some of you are familiar with the Acute Care Surgery Fellowship or the Acute Care Surgeon. So this is actually a concept that was born out of a need. 20, 25 years ago, there was a recognition that trauma was becoming less of an operative profession. And so we had the development of CAT scans and the development of watchful waiting for solid organ injury. We sort of morphed away from doing exploratory laparotomies just for the sake of making sure that there was nothing wrong in terms of admitting the patient and doing serial exams and less operating. So fact was that less surgery residents were interested in being trauma surgeons. It was great to do it during your residency, but once you got out into practice, it was a lot of call. It was getting up at night. It was not operating. And so the Acute Care Surgery Fellowship was born to incorporate not only trauma care and critical care, but also operative care for acute care surgery, which included surgical emergencies like appendectomies and ruptured diverticula and cholecystectomies and the other types of surgery that general surgeons learn to do and love. And so this became a very popular profession. Probably many of these individuals practice in your trauma centers. And so we did a gap analysis recently to look at acute care surgery fellowships for the provision of a rotation in pediatric trauma care, understanding that the reluctance of a lot of trauma surgeons to care for children is really experiential. And we were able to survey 4 years of fellows and just ask them about their experience as well as their interest. And most of them were planning careers at level 1 trauma centers, but some were interested in global surgery and military surgery. And certainly if you're going to do global surgery or if you're in the military, children can be collateral damage, but they can also be an age group that shows up wherever you're doing global surgery, and they may need surgical care also. And so we found that there was actually quite an interest in at least a pediatric surgery rotation during their fellowship, but there were also a subset of individuals who were interested in maybe having a little bit more than just a rotation. And so we've been able to develop an ACS pediatric subtrack. It was just opened a month ago to applications. And what it will do during that 2-year fellowship is allow a person to do a month of pediatric critical care and 2 to 3 months of pediatric trauma and pediatric surgery. And the goal is not to compete with somebody like me, who's a fully trained pediatric surgeon, but to identify and train a subset of fellowship trained surgeons who have more experience with children and maybe selecting a practice environment where they take care of adolescents or where they're going to take care of some children and would feel more comfortable if they've had additional training. And this will be a joint certificate through the WAST, the American Association for the Surgery of Trauma, which is where the fellowship resides, and the American Pediatric Surgical Association, which is our main pediatric surgery association. And this is the banner on the WAST website. Ultimately, although I'd say a lot of the fellows go to level 1 trauma centers, as we talked about, there are many level 1 trauma centers. In fact, many of them are in California, where children are cared for in the level 1 adult trauma center, and it is not verified for pediatric trauma care. So where does burn care for children fit in? So this is another really huge gap, and you can see the map in the right upper corner that looks at where the verified burn centers are. There's been a paradigm shift, probably because of the gap in where burn centers are located in surgical training for burn care. So a burn rotation is no longer a requirement. Part of the issue was the lack of experience in burn care at some of the surgical residency programs, which meant that the residents had to go away for a rotation somewhere, which adds cost and a travel burden to the residency program. So there was an appeal to get rid of that mandatory burn rotation. So instead, there's now a requirement for core knowledge in burns, as well as a requirement for complex wound care, but surgical residents no longer have to do a burn rotation. And I think that the ultimate concern is that this will affect both children and adults in the future who require advanced burn care. And it also means that if you have a large burn, you have to travel often to a burn center for your care, which is a significant burden on your family also. So through the PPN network and a partnership with the American Burn Association, we have developed a survey, which is currently deployed out to level 1 and 2 adult and pediatric trauma centers, verified burn centers. And then we're in the process of understanding where the state verified trauma centers are so that we can send the survey to them also. the goal is to understand where everyday burn care is delivered to children. We know that many children's hospitals, for example, provide burn care to children, and they are not necessarily burn centers that are verified by the ABA. And so the first thing that we want to do is know where that care is being delivered. And then hopefully we'll be able to design a better local and regional system to support the provision of pediatric burn care, but also to encourage bidirectional flow of information between the ABA and centers delivering pediatric burn care. And so I hope that by mid-year, we'll have some information, and then we'll be able to develop an action plan with the ABA and the Pediatric Pandemic Network to better define the goals and where burn care is delivered. Next question, why should trauma system development include both children and adults? So of interest, when trauma systems were first developed, thought of, they were really adult-based and children were left out. There was a conference in 1998 called the Skamania Conference on Trauma System Development, which was a think tank of trauma surgeons in the country. One of them being Brent Eastman, who was practiced in California for years, and one of the leaders of trauma care in this country, and was also a past president of the American College of Surgeons. Don Trunke, who started out in California and was the trauma chief in Portland, Oregon for years. And Dr. Trunke and Dr. Eastman did this conference, brought together all of these preeminent people in trauma care. It was organized by Rich Mullins. And Frida Halka, who was doing a research year, was the first person to actually write about pediatric trauma system development. So this was when trauma systems were really starting, and a trauma system is usually state-based. In fact, every state in the nation but one has a trauma statute that defines their system of care. Sadly, some of them did not consider children when they were developing those laws, and we all know how long it takes to change a law. But at the point when Frida wrote her paper, both Oregon and Washington were either had trauma systems or were developing them. And what she did was she compared Oregon and Washington state. At that point, Oregon had actually implemented their system and Washington was in process. And although both states showed a similar trend toward a declining frequency of death for children hospitalized with injuries, seriously injured children demonstrated a reduced risk of death in Oregon, where there was a functional trauma system that included children. So why should a trauma system be integrated into state planning and development? Trauma care in this country has been spearheaded by the American College of Surgeons. And they, I think, pride themselves on the Committee on Trauma and all of the great advances they've made. But trauma is not an island, and it needs to be integrated with emergency planning and development in the HPP programs in order to make it more functional in an integrated system. I know that many of you are aware of a project that I did that was released about a year or so ago. So I'm only going to mention it briefly. But until I was funded by the Childress Institute to do this study, there really had not been a comprehensive look at pediatric trauma system development in the country, partly because many of these states instituted their trauma systems, but really left children out. This particular report looks at every state There's a state abstract that provides about 80 different metrics. It does lead to a scoring system, which is broken up by domains, which are on this slide. And I'm pleased to say that the Pandemic Network has funded this project so that we will be able to continue it. And we're in the process of hiring a data analyst and a program manager so that we can reassess the states now that they've been through the pandemic and there's been more disaster planning. And I'm sure many states will have improved their scores, but we'll also look at the different metrics that go into these domain scores and try to enhance them and provide a data dictionary and drill down into a way that states can improve. Caroline Stevens, who might actually be on this call, also helped me write a paper that looks at an agenda for building a national pediatric trauma system. So it operationalizes the score and sort of gives a playbook for how to improve a trauma system in a state from the children's point of view. Last thing I wanted to talk about briefly is something that probably many of you, if you're involved in a WRAP-EM state, already know about, but that's how to build a preparedness network for children. And we are a primarily rural state. We have just over 100 hospitals. We only have about 4.5 million people. We only have 2 level 1 adult and pediatric trauma centers and 1 level 2, and the rest are 3s and 4s, of which about 22 of our hospitals are trauma centers. And before the Pediatric Pandemic Network was started, children really were not well integrated into the system of care in Kentucky. When the grant started, or the year the grant started, we had a big tornado in Kentucky that claimed the lives of several children. And by accessing the trauma network, I was able to reconstruct a look at where all of those children went and the care that was provided. And actually our voluntary trauma system worked pretty well. But the other thing that it did for me is it provided me access to many of the people that you see on this slide. Abby Bailey is my program manager with a strong history in EMS. Karen Orman is critical care, but she's also the director of transport, and she's developed a very fine simulation course that we can take to rural hospitals to help them build pediatric readiness. And then Ken and Angela Kick are at the state level in HPP and emergency response. Angela is Ken's wife, and she is part of the public health network in Kentucky. Sorry about the dog. And so what we've been able to do is bring together all of these people from the hospitals, emergency management, EMS, the leaders and stakeholders who come together when we have a disaster. And we've not only had tornadoes, we had a huge flood in Appalachia because of strip mining and deforestation. And then we've had forest fires this past year. And so what it's done is bring all of these different people to the table with the intent to do a few things. So these are our healthcare preparedness program coalition regions. And we have also just been funded through the PPN grant to hire a pediatric medical operations coordination person who will, as their full-time job, integrate pediatrics into every one of those healthcare coalitions, assist with our strategies for family reunification. And we're also hoping to develop a more formal state response relationship between the PPN and our network of state officials. as well as the children's hospitals. We have that in planning and development. Just to sort of recap, I think that trauma and burns, especially a focus where you live, are things that sometimes don't receive as much hype as infectious disease these days, but they are still the leading killers of the children in our country. I think that it is short-sighted to think that all injured children are going to get transported to tertiary and quaternary care. And we as leaders need to be good stewards of communication and develop those networks that will enhance the ability of the clinicians in smaller hospitals in rural areas of our country to provide better care for children and to get them to us if they need to get to us, but also to keep children home if they don't really need to travel 300 miles to a quaternary care pediatric trauma center. Trauma surgeons should be interested in pediatric readiness because they're the ones that report to the trauma room when a kid is critically injured, and they need to be aware of what their emergency department is qualified to do and who's there to help them on the team to take care of a child, to either take care of them there or to get them ready for transport. Burn care for children is something that we can't forget. And I think with this grant, we're going to be able to emphasize that a little bit better in the future, as well as hopefully to provide some better advice when children first appear in a rural emergency department. And trauma system development should include both children and adults because children are 22% of the population of the United States. And they get hurt where they live, and that's where they go to be seen, at least initially. And a trauma system means that we're going to provide great care for all of our citizens, not just adults. And a trauma system should be integrated into state planning and development because it's part of all hazards. And many things that occur can involve injury, and we have to be ready for that. But our emergency management and HPP providers also need to know who we are, and we need to be working together. So with that, thank you very much for your attention, and I'd be happy to answer questions.
Hey, Mary, that was fantastic. I think several things that are highlighted that we just have a long way to go to care for children with many different conditions in the United States, and the capacity has changed quite a bit. There was one question in the chat which was targeted to your slide 35, which showed the maps. And you may know this, how many states do require ACS guidelines for 4s and 5s? And that is, anyway, I'll let you respond to this because I have some knowledge about this.
So if I understand the question correctly, it's do ACS criteria apply to level 4 and 5 trauma centers in states where they're where level 1, 2, and 3? So I'd say that it varies by state. And I can tell you anecdotally in Kentucky that our regulations were written when we first started our trauma system. And now that the pediatric ready standard has been released, we are going back and looking at all of those in regulation, because we have to send it back through state government to get it changed. So if states are like us, it's quite a lift to change regulation. And sometimes it's tied to other things that you may not actually want, but that's how it gets through. And I'd say for the most part that it's probably different than it is for the verification standards. So states that are state verified or have level 3s and 4s are going to have to go back and look at their standards and amend them if they want to do a pediatric readiness standard.
Yeah, and just one other follow-up question to that. My understanding is that in the latest book on the optimal care of the injured patient, that outlines for level 1, 2, 3 are there, but not for 4s and 5s. They were in the previous book, or 4 was in the previous book. So I mean, ACS doesn't, can you talk about ACS verification of anything but a level 1, 2, and
So
3?
ACS has never verified level 4s.
Yeah.
They're talking about it. And there's, I believe, starting to develop some standards, but right now they do not verify level 4s. And so just to orient people, so level 1 is a center that's at an academic institution, and there is a requirement that you do research and write papers. A level 2 is really very similar to a level 1, except that it's typically not in an academic institution, doesn't have many residency or fellowship programs, and it's not tied to the same scientific requirement of research and writing papers. A level 3 is generally a community-based, or it could be a more rural hospital, but it has more resources. It does have surgical subspecialties, and it has agreements with level 1s and 2s to transfer to a higher level of care when needed. A level 4 is, or a 5 is really a hospital with a great emergency department, capable of stabilizing and transferring a patient, but they do not necessarily admit trauma patients. And 5 similarly is going to have that capability of stabilization and transport, but probably not admitting a patient.
Yeah, that's what we found, and just looking at other states creating our trauma regulations is just that. And for this group, as you know, there's certification, verification, designation, categorization, regionalization. There's different terms that are used, but generally designation is by a governmental authority who ensures that certain standards are there, and it could include ACS, certification, which some states do, as Mary's pointed out, and we're looking at that in California. But for the level 4s, 5s, those are generally designated through this governmental authority. It could be the state EMS office, it could be regional EMS, it could be a Department of Health. There's a number of possibilities there. So anyway, trying to address that question. I don't know if there's any other questions in the chat. Mary, I have a question, because I just want to know about burns. You've emphasized the big gap in care of burns, and we certainly see this in Los Angeles County, having and we're, over 4,000 square miles. We have very few burn centers, and really one only designated for care of children. So we have opted, and I'm just curious, and this is a question, and see if you're aware that other states have done this. In any burn surge and also critical burns, we're asking them, unless there's an immediate airway emergency, we're asking our EMS to transport them to trauma centers, because we feel that we have 15 trauma centers, so they're more likely to be able to have people on site that could resuscitate a child, especially with the burn, and then we would initiate secondary transfer to a burn center. So I'm just curious if you know if other states have done that. That's the way we've tried to, deal with that issue.
It's a good question. It's a valid question. I think the slippery slope is the hazard of taking a child with a really minor burn and helicoptering them to a children's hospital when some good communication might have avoided that expensive trip for a fairly minor injury. So if a child is a major burn plus inhalation injury, I think getting them to the children's hospital or the children's center or the trauma center expeditiously is the way to go. But being in a rural state, I've also had a number of children show up either by ambulance or on a helicopter and really could go home or could have gone home from that rural emergency department and been seen the next day in clinic. And it's very expensive care for someone who feared a burn. So I think we have some education to do, and again, better communication between a place where that kid shows up first and the tertiary center could avert some of this expensive care that's unnecessary. So trying to qualify what you said, which is what is a burn and what is a burn that requires going to a trauma center versus what is a minor burn that could really just stay at home and be seen in clinic the next day are the spectrum of things that we need to deal with when we try to do this gap analysis.
I think that's helpful. There was a question in the chat about, going to the closest adult center, verified center, versus one that, or non-verified center, sorry, that is 4 hours away. And I think first of all, it is expensive and it's challenging in a number of ways to take children out of their community. So I think probably going to the emergency department, at least having an evaluation, and I hope the EDs would have a transfer plan as a part of their pediatric readiness and be able to reach out, as Mary said, to a regional either burn center or a tertiary care center that may have more experience with taking care of burns to make a decision on that. So peds trauma gap, I'm trying to. All right. Are you aware of any studies looked at the impact of catastrophic events such as earthquakes in California on trauma center capacity? And I know we're out of time, but go ahead. One last question.
Yeah, I am not. It's Dr. Schreiber. I am not aware of any studies that have looked at that. Doesn't mean they aren't there. I'm just not aware of them.
Yeah, that's a big issue. I know we had problems with the Northridge quake here, but not trauma care per se, is more some of the availability of water, formula, diapers,
Right.
those kinds of things for displaced people. But is there a link on the WRAP-EM site? Last question from Hillary. Great resource. Oh, okay. You responded, Dave. Well, can you all join me in thanking Dr. Fallat with greater than 30 years of incredible advocacy? And every time I hear you, I just go, oh my God, the amount of work and time to really advocate for children. And I just, from all of us at in EMSC space and WRAP-EM and PPN, thanks.
You're welcome. Thank you all.